Grant. I'm our next speaker, Grant Miln, and he is going to talk about what imaging is really necessary and how can photon counting detection be integrated into the cath lab. Thank you, Grant. We're excited to hear your talk.
Super. Thank you very much for the introduction, Iris, and thank you very much for the invitation to come and present to you all today. So hello, my name is Grant. I'm a senior specialist radiographer in NHS Scotland, and it's my pleasure to talk to you about acute stroke pathways and how photon counting detectors are going to improve these services. So we all know mechanical stroke thrombectomy is recognised as one of the most effective clinical treatments in modern medicine. Most recent data showing 49% of thrombectomy patients achieve independence post-procedure versus a 13% treated with medical therapies alone. This means far fewer patients are facing these lifelong disabilities, such as paralysis and speech deficits, which would otherwise place a significant burden on health services and on families. And while the best results are found in patients who are treated within the first 4.5 hour mark, benefits persist up to 12 hours and even 24 hours post-stroke in certain cases. But rapid assessment and intervention are key for these achieving the most favourable outcomes. So how do we know which patients we can and cannot treat? While MRI is considered the gold standard in stroke imaging, CT is the modality of choice due to its rapid acquisition, widespread availability, the ability to quickly exclude contraindications, and practically no patient restrictions for bringing them in, especially when compared with MRI. So what key markers do we need to be able to identify from the CT? We need to determine, first of all, is there a large vessel occlusion? Is it in an achievable location? And does the patient have traversable anatomy? We need to also determine the patient's aspect score. An aspect is widely regarded as a clinical standard for acute ischemic stroke assessment, but not universally considered the gold standard due to its limitations of sensitivity and variability in human interpretation. So with your aspect score, everybody starts off with a score of 10, losing 1 point per area of established ischemia. Anything greater than a 6 considered for mechanical thrombectomy. Anything greater than 3 has survivable outcomes, but with less favourable ones. Collateral assessment, as we've probably heard today, is another key indicator for mechanical thrombectomy. The collateral circulation maintains and perfuses the tissue at risk, delaying the infarction and extending our therapeutic window. Good collateral scores are correlating with a high reperfusion success and better functional outcomes. So now we know what we're looking for. How do we acquire it? Currently, there's no standardized practice in acute imaging protocols. The current literature advocates for a non-contrast CT head to attain your hemorrhage and aspect score, a multi-phase CT to identify your LVOs, detect any distal clots or occlusions, and to generate your collateral assessment. Perfusion as well also can help guide the penumbra and salvageable tissue, as well as eligibility for thrombectomy in our delayed presentation patients. But looking at the current literature and the current technology that's out there, this method of acquisition does have some limitations. It delivers a significant dose to our patients. Standard multi-phase CTs as well are usually timed rather than bolus tracking, which can produce either underfilled or late-filled angiograms. And again, some of this, the more complex and advanced imaging, is requiring some post-processing as well as motion artifact management, which all adds and delays time against the rapid decision-making process. But there is a solution. The introduction of AI systems into the acute stroke pathway has been reported to decrease delays in treatment by up to 65 minutes. And when talking about stroke, the mantra of time is brain is key here, and 65 minutes has a significant impact on treatment outcomes. With AI, interpretation is not only then quicker, it's also standardized. So your LVO is automatically identified, aspect score generated, and collateral assessment complete, all laid out in a nice, easily accessible format. Core infarct and tissue at risk areas, we can see here with the Brainomics tool, is validated against MRI. So we know that the results are accurate and reliable, even before the 6-hour window. So sounding good, what do we need to achieve this level of clinical detail? 2 CT scans is all we need. So a non-contrast CT head and a single-phase arterial angiogram, starting from arch all the way up to vertex. And this provides clinicians with a wealth of validated and rapidly acquired data in order to make well-informed and well-supported decisions. And this is the current imaging pathway that we use in my hospital as well. So just 2 CT scans for every stroke patient. And while AI integration is an important step technologically, I'm also pleased to present another game-changing technology, which is hopefully going to really improve our stroke management. Our reliance on CT technology is on an ever upward trend. And while the technology has evolved dramatically since its inception, with faster imaging, better resolution, and more accurate results, it's all still based on the old energy integrating detector, where you turn, is that video playing? Yes. Where we turn X-ray photons into light, into electrical signals, and then into an image. This is a very inefficient way of processing the data, particularly in the light conversion stage, and we do lose a lot of detail. Photon counting detectors, however, are brand new technology that have revolutionized this inefficient process. With PCD, the energy from every single X-ray photon that reaches the detector is measured and then instantly translated into an electrical signal. This means we now have access to a form of X-ray spectroscopy for every single slice of CT data, allowing us to differentiate our materials based on atomic numbers. Due to the detector construction as well, we can achieve much thinner slices down to around 0.1 millimeter slice thicknesses. And again, all of this is with lower doses. One of the big advantages I would like to highlight, which is particularly useful for stroke, is the ability to differentiate between contrast and hemorrhage. On the images, you'll see that I've got an iodinated contrast media staining part of the patient's brain there. Using a simple post-processing technique that takes seconds to do, you can remove that contrast, leaving hemorrhage and allowing us to guide management a lot more effectively. And all of you will know how important this is going to be able to differentiate between these two materials, which is currently we cannot do, with CT anyway. There are currently only 2 providers of PCD, Siemens and Samsung Neurologica, with the latter having released a mobile PCD scanner particularly aimed at stroke patients. This scanner is more accurately able to assess infarct volume, as well as assessing clot morphology. And all of this while being able to potentially scan the patients at bedside or even in the community, with the idea of helping to potentially triage our stroke patients even quicker. Post-operatively, stroke thrombectomy practice sees that every patient has a CT performed in order to check for post-operative complications such as hemorrhage. These are often performed within the cath lab and can be of variable quality due to the nature of flat panel acquisition. But with the advent of PCD, we're able to better assess post-operative stroke infarction, produce images with reduced metal artifact due to its inherent nature and the technology it's based on, and then have the advantage of being able to differentiate between contrast and hemorrhage before the patient has even left the lab, allowing clinicians to more aggressively control post-operative blood pressures, which is another significant impact on patient outcomes. So to summarize, we believe that stroke care is in the middle of a technological revolution, with potential integration from AI into these pathways and the advent of PCD technology, both helping to streamline the imaging processes and pathways and making decision-making processes, ultimately improving the lives and outcomes of our patients. So thank you once again for your time, and if you've got any questions, I'll do my best to answer them.
Your wonderful presentation. Any questions? Yes.
Thanks, Grant, for this beautiful and such a clear talk. I think what is especially appealing to people in the field is the differentiation between bleed and contrast. How do you and others, how do you think this will change what we conventionally know from the literature regarding the occurrence or the risk of bleeding in stroke or carotid interventions. Sometimes you are really not certain. This importantly impacts management. You stop the double antiplatelets, or you give 1, or you give 0. There's an increase in stent thrombosis. So how do you think this will influence the data that we are used to having so far?
I think it's going to be a bit of a game changer. The accuracy we can now apply to our reports is ultimately going to only benefit our patients. We can pick apart piece by piece where the contrast is, where the blood is, and differentiate between in a way that we've never been able to do before. I really do think it's going to change how we're managing our patients and give us a lot more scope to manage them a lot more aggressively, which we know can have a direct impact on our outcomes.
Is it going to be a separate machine, or in the next few years part of the same CT scanner?
A lot of companies are going ahead with trying to integrate PCD. It will be, because it is a brand new detector technology, it requires a whole new scanner gantry. But they're already on the market, and I think it's sort of the integration that we've had with iterative reconstruction. That was a big improvement, especially for dose and image accuracy, and that has now been sort of maintained as a standard as we need for all CT scanners. And I think PCD is the next step forward into that, and it is a proper game changer for that. So it will be, in the next 10 years, all the new scanners will probably be PCD.
Are they physically one and the other, the old and the new one, or can they be integrated into one?
Oh, I don't think they can be integrated into one system.
So the FDA have said photon counting detection is the biggest innovation in imaging, and they predict that in 10 years, all CT scanners will be replaced with photon counting detection. It is less radiation. It's an up to 10 times higher resolution. So at the moment, the prohibiting factor is the price. But there is it can only do more than a normal CT scanner. You will not need the CT scanner anymore. It will be replaced by the photon counting detection, because the only difference is in the processing. You don't need the energy, as Grant was saying, by the photodiode anymore. You immediately have the energy of each individual photon, light photon. And of course, as you were saying, management completely changes the management. How often do we have a situation where we had to place a stent, or where we would like to give more aggressive antiplatelet therapy? And we're afraid because we do not know yet, is the patient going to bleed? Is there any area at risk? Or we do the flat panel CT and we see white stuff, hyperdensity. We don't know, is it blood, is it not blood? So now I can have the reassurance and say, okay, it is not blood, it is contrast extravasate. Or I know it is blood and I am much more cautious. So I think it is going to be a game changer.
Yeah.
Yes.
There's just from one of the talks I saw this morning about device selection for red and white clots as well. The hope is that PCD will be able to differentiate between red and white clots in your preoperative staging, so you can choose and tailor your device management a lot more appropriately, hopefully reducing any further complications as well.
Contrast those the same?
Yeah. I mean, you could. I think
Much less.
I think we can actually reduce it. Yeah.
Yeah. So we have shown that we could do visualization of the vessels with as little as 3% of the normal contrast dose. So it was probably just about visible, but you have a massive. So most centers would reduce contrast by half the amount of contrast. So massive reduction of contrast. Yes, it is going to be a game changer, and what especially for the interventional world, having a mobile PCD scanner, that is that you can have in the angio and you can just push in. It has a battery life of 90 minutes. So you could already switch it on before you do the intervention. You just add it, put it over the scan it, with the normal extension. Also on the ward, if the patient deteriorates, bring the PCD scanner up. Those patients do not need to be transported. Usually we have difficulty differentiating intracranial stents, or if there was clipping inside, metal artifacts. Take that energy value out, much better resolution. We saw you were showing a beautiful picture with your PCD scanner of a clip. So artifacts are much, much less.
Will there be a difference in the mobile system and the standalone one?
Basic, very similar. Very similar, but the disadvantage is that it has a 40 centimeter burr hole only, so it can only do the head and neck.
You know from MRI,
Not
mobile systems, it's the size goes
Yes.
with detrimental effects of the quality.
Yes.
And in this case, not. So the quality will be the same in the
Yeah.
mobile setting and the standalone one.
It is a game changer. It has just received CE mark. It has FDA approval, so it is now available. And I think the price is the only prohibiting factor at the moment.
You can go down to the arches.
No, 40 centimeters. Well, in a kid, 40
In-
centimeters per hole.
Yeah, in a static system you could. So the Siemens has static systems, but not in mobile
But
because of
let's
the borehole.
continue with our next talk. Grant, thank you so much.